starts here. I am your host, Olivia Moyer, and we are here at the Institute for Women's Health here in London at UCL. And today we are going to be covering PCOS, which is also known as polycystic ovary syndrome. And to do this, I have with me Dr. Basil Wattar, who is a consultant obstetrician and gynecologist based in London. He has advanced expertise in various areas including fertility, assisted conception, endocrine gynecology, menopause, and of course, importantly for today, PCOS. So very interestingly, he is the co-leader of a research group dedicated for evidence synthesis at UCL, which is something that we've talked a lot about on this pod, and really the importance of having evidence-based research. So it is such a pleasure to have you here with me today. I always love to start off a little bit of backstory, so maybe you can give us maybe a quick run through of how you got here today, and really why you're so keen to study PCOS, and briefly a little bit on your evidence-based research group, EV.
Lovely. Thank you for the kind introduction, and thank you for having me here today and covering an important topic like PCOS. Backstories. Oh gosh, I'm not sure how far to go back, but I'm originally Belgian Syrian, and I came to the UK immediately after my med school to do my advanced training in obstetrics and gynecology. A lot of people ask me why OMG, and to me it's like the utmost satisfactory discipline, because you're helping, creating families and helping, mothers stay healthy, and that's the key, in my opinion, to a healthy family and a healthy society. So it gives a lot of satisfaction, and I'm quite glad I went in this very long venture. Endocrine and fertility. So I guess a key exposure when I was in my first year of training, I got a sort of opportunity to do some early research on a intravaginal probe that was detecting changes in temperature to detect ovulation, and that sort of sent me on a rabbit hole of when ovulation happens and how menstrual cycles regulate and what the hormones are. And I still to this day find it ever fascinating, because we just have so many sort of question marks, and we still have a lot to understand. And sort of PCOS is the pinnacle of so many question marks still to unravel. And while there is more and more research, and we do know quite a bit about how to manage it and deal with its consequences, till this day we don't really know the main cause of PCOS, like where does it start. And it's sort of the chicken and the egg story, because people who are gynecologists like me tend to think it starts in the ovaries, while endocrinologists tend to think it starts in the brain and the hypothalamus, and where the hormones are secreted. And this imbalance between the hypothalamus and the ovaries is all dealing with all the causing this imbalance in hormones and leading to these different symptoms that women with PCOS tend to suffer from. So yeah, extremely interesting. I still find it interesting and enjoy researching it, and most importantly, enjoy looking after women with this condition in the NHS.
I love that. I love hearing about where it kind of starts, and I agree. It's so important, and I think so interesting to start off with studying things relating to the beginning of life. Where we all come from and what goes into that. So, in terms of bringing together the evidence-based research, you started this, or you're co-leading a group on this kind of research. What is that? You focus on different topics.
Yeah, so the group is called EV, Evidence Synthesis and Methodology in Women's Health, and we are dedicated to women's health. And the idea came about that if you look across London, there's so many different, leading universities that are really top class in medical research, but actually there is not even one single research group that is doing evidence synthesis in women's health. And evidence synthesis is sort of, for our audiences, in very simple terms, the process of translating research and putting it back into clinical practice. And it goes from doing systematic reviews, meta-analyses, clinical practice guidelines, and so on and so forth, assessing the evidence, putting down findings from different studies so that we can have more confidence, more precise results, and then that could help guide clinicians in the practice of evidence-based medicine, because that's what we would like to offer our patients, is that we're offering them the best quality clinical advice that is underpinned in top quality research, and that is what EV really wants to achieve. So we are a vibrant group of both clinicians, methodologists, systematic reviewers, statisticians, health economists, which is a sort of a combination of different talent across UCL. And we look into, so currently we're looking into a big project looking into treatments for heavy menstrual bleeding, which is funded by the NIHR. We do a lot of research on PCOS, on menopause, PMS, and obviously fertility and assisted conception technology in terms of assessing what treatments are good in IVF, how can you maximize the success rate at IVF, and obviously there's more and more reliance on assisted conception. So that's really the story behind why EV came through, is just to fill a gap and a need for better evidence to inform clinical practice in the domain of women's healthcare.
That's fantastic, and it's honestly just mind-blowing that it's the only group amongst all of these universities that are focusing on that evidence-based kind of research. We really need more of that, especially with women's health.
And we need more researchers. There is a steady decline in the number of researchers in women's health across the UK. I'm talking specifically for a variety of factors, and if we can achieve something from today, is to inspire more and more young sort of doctors to come into women's health research.
I love it. Yeah, absolutely. So we sort of began to talk about PCOS. You said that there's different causes. We don't really know. It could be hormonal, could be something to do with the ovaries. We're not really exactly sure where it starts, but if you were going to just broadly cover for everyone listening who maybe doesn't know as much about what this condition is, what would you say are the main kind of characteristics or things to know? Like, what is PCOS really?
Sure. So it's important to call it a condition, not a disease. It's not a disease. It's a chronic, so it's by far the most common endocrine disorder affecting women. So it's really, really common, and people underappreciate how prevalent it is. Technically, in the UK, we estimate between 10 to 15% of women to be affected by PCOS. It's a really common condition. And it starts from the early adolescent years and goes all the way to menopause. So it evolves, it changes how it manifests. And most importantly, as it's a syndrome, it has a collection or a group of symptoms that manifest, but it manifests differently in different women. So not everyone with PCOS will have the same symptoms, and these symptoms will vary in severity from one domain or the other. So that what makes it a little bit challenging to diagnose it and managing it, because it's not like a disease where you give one tablet, that's it, you're cured, carry on the tablet. It doesn't work that way. So the main diagnosis of PCOS is based on something called the Rotterdam criteria, which is established about 20 odd years now. And you need to have 2 out of 3 symptoms, not really symptoms or sign. So either irregular or absent periods. When we say absence, more than 6 month no period. Excessive hair growth or acne on the hair, on the face, chest, arms, where a woman would not normally have excessive hair. And plus minus an appearance of multiple cysts on the ovaries on ultrasound scan. Now they're called cysts. They're not really pathological cysts. They're basically follicles that are arresting. They're not developing to ovulate, and thus they stay in the ovaries, and they give that sort of very distinct appearance of multiple follicles in the ovaries that are between 2 to 9 millimeters. They need to be more than 20 as per the new sort of guidance from the International PCOS guideline. And basically, if you have 2 of these 3 symptoms, you're diagnosed with PCOS. The key feature is that these women often don't have any periods, which have a lot of health problems. They do not ovulate, and as such, they can't get pregnant without any help. Again, I emphasize, not everyone has the same symptoms. They have excessive hair, which can have really severe body image and self-esteem sort of implications, and there's high prevalence of anxiety and depression in this sub-cohort. And they also have insulin insensitivity, meaning there's high insulin resistance in their body tissue, and therefore they're having to secrete higher levels of insulin, and yet the body processes sugar in a less efficient way compared to someone who does not have PCOS. As such, about 50% are either overweight or obese, because their body converts sugar so quickly to fat, and it's so much harder for them to lose weight. So it's a sort of a vicious cycle where this imbalance of hormones keep feeding into more and more adverse symptoms. Now, long-term, PCOS also have long-term implications in that these women, as you probably have guessed, they're at higher risk of type 2 diabetes, so they need to be watchful of it, and primarily with lifestyle intervention, but also with other treatments, we can cover them later. There's also, because they're not having periods, their endometrial thickness is increased, and they're more at risk of having something called endometrial hyperplasia, which is the precursor for endometrial cancer. So it's important for them to at least have one period every 3 months.
Right.
And again, is the mental health challenges that I manage that are unfortunately often brushed off and not covered very well in healthcare services for many reasons. So that's sort of a summary of what are the common symptoms that women with PCOS would suffer from.
Yeah, that was great. I feel like I understand it so much better myself. Okay, so then thinking about treatment, so obviously, as you said, there are different symptoms depending on the person and severities, I'm sure, of the PCOS affecting whoever has it. But if you were going to say, just in general, how you manage PCOS, what is the normal kind of standard protocol with that?
So, as I mentioned, the key message is to have individualized management plan. So it's not one size fits all in PCOS, specifically in medicine in general, but specifically in PCOS because each woman will have different symptoms. Mm-hmm. The other key message is early adoption of intervention. So often a lot of these women would experience delayed diagnosis because a lot of health professionals are either inconfident or they don't know enough about the condition, talking specifically GPs in the community. So they're afraid of calling it PCOS, or they delay having all the different investigations and therefore the diagnosis is delayed.
Right.
And so a large proportion will actually be labeled PCOS when they come to see a fertility specialist like me, and we do investigations while you're not getting pregnant, and we find out when you have PCOS you're not ovulating, which is what, late 20s, early 30s, while in reality they probably could have been diagnosed in the early 20s, late adolescent years, and they could have started sort of lifestyle interventions or other treatments that could help them reduce the impact of PCOS.
Okay.
So the first line, if there is now, luckily we have an international PCOS guideline, and it's led by Monash University in Australia, but it has international sort of input, and a few of us in the UK has contributed to it. So, and the first step in the guideline is lifestyle intervention. And I don't want to sound like I'm lecturing and say it's diet. It's not. So it's lifestyle interventions, as in look into the patient's lifestyle and see how you can optimize it. So can they increase exercise? Exercise doesn't need to be going a CrossFit. It could be just having regular brisk walk. It could be taking your dog for a walk regularly, for example. It could be having yoga or Zumba or Pilates. It doesn't need to be a strenuous exercise. Smoking cessation, and most importantly, dietary intervention. And so if you extrapolate on what we discussed about the insulin resistance, you can pretty much guess that these women cannot take a lot of high glycemic index diet. They cannot enjoy chips or ice cream or so on, all their guilty pleasures of life, unfortunately. So it's important that we support them to understand that. Now, unfortunately, I think in the health service we're very good in dismissing it and simplifying it and say, oh, go eat 5 pieces of fruits a day. Like, this is not going to resolve the problem. You need to help them to understand their trigger foods. So when someone is being emotional, often you grab a piece of chocolate, and while it sounds like a two seconds thing, it actually has a lot of impact if you have PCOS. And also about following a distinct sort of dietary regime. So I recommend to my patients either a Mediterranean diet to maintain weight, they're not going to lose weight on it, or an intermittent fasting or keto diet to do a short burst of aiming to lose weight, and then you do it only for a few weeks, try to lose some weight, and then you go back to a maintenance diet. Because I'm sure you, myself, and everyone listening have tried to go on a diet.
Absolutely.
You can't do it for more than a month or so. You'll just revert back to your normal lifestyle. It's just the nature of it. So, it's important when we are counseling women with PCOS, don't sound like, you just need to lose weight and oversimplify it. It's really hard, and we need to understand it and support with a lot of information and teaching, education for the patient to enable it. So that's the very first line intervention.
Mhm.
Then if we sort of reverse engineer from the symptoms we discussed, you need to give them a period at least once every 3 months, so that either go under contraceptive pill
Mhm.
to have regular periods, or sometimes have a withdrawal bleed with a progesterone only pill that they take for 5 to 6 days every 3 months to have another period.
Mhm.
Some will prefer to have a intrauterine coil, which releases progesterone internally, which is more effective. But again, you have to tailor it to the patient, age group. Someone who's 20 years old will probably not want to have a coil,
Right.
or someone who's late 30s and had her children, probably she wouldn't mind it and she'll find it advantageous. So it's important to consider the different sort of individualized characteristics. Treatment of hair cysticism and acne, so that could be either with anti-androgenic agents within the pill.
Mhm.
So some contraceptive pills have this sort of hormone,
Mhm.
or you could just use an anti-androgen like spironolactone or finasteride, for example. They're becoming more and more prevalent, and actually there's been a very recent RCT in the BMJ probably a couple months ago, which showed significant improvement for hirsutism and acne rather, not hirsutism, with spironolactone, and that's safe. So there's more sort of uptake of these treatments to help women with these symptoms deal with it. Some don't want to take pills, so they resort to laser treatment or hair removal. Unfortunately, they're not available in the NHS everywhere,
Yeah.
and so they can be quite expensive to access to everyone. And then, beyond that, we can talk about the fertility treatment, which is a completely separate topic, and surveillance. So that's very important. So as we discussed, they are at high risk of diabetes, so we'd recommend at least a yearly test for their blood sugar to check that they're not edging towards diabetes, because you can always do an intervention to bring yourself back to safety.
Right.
And as we said, if they're not having periods, they're at high risk of hyperplasia, so it's important to continue with that. And lastly, the mental health elements, and this doesn't always need to be in healthcare sort of services, professional healthcare services. Sometimes just engaging with a peer support group could go a long way in offering support. And I always tell my patients, look at the Verity PCOS charity, which is the UK charity for it. They have wonderful resources and support groups for women that would really help them deal with the symptoms and cope with everything that they have to go through.
Yeah, it sounds like, obviously it just sounds a lot like the sort of empowerment around this topic and is maybe lacking, and giving women sort of that feeling that they're not just kind of making it up, or that these things are valid things, and as you said, don't put all the emphasis on diet, but feeling like those little bits can make a difference. I think, because as you said, or alluded to, it's just that maybe sometimes all of the little things in combination might make a big difference overall, or at least helping to manage the symptoms that you're going through.
100%. And as you rightly mentioned, is that sometimes a lady would come and say, look, my main problem is that I'm not able to get pregnant. She get diagnosed with PCOS, but we are guilty as health professionals is that we don't probe for the rest of the symptoms.
Right.
Unless you ask someone, look, so they have higher tendencies of sleep apnea and snoring at night. If you're not going to ask for it, they'll think, oh, it's just me because I am overweight, I just snore. No, it's a consequence of PCOS, and you need help with it because it can put you at high risk of cardiovascular disease in the future.
Right.
And same if you say, look, do you have anxiety, depression? How do you see your body image? If you don't probe for them, if you don't believe and help them to explore it, they will not even know how to start to seek help. So it's important to keep a comprehensive perspective about it, and be open-minded and helpful about exploring the different symptoms.
I love it. I love how much you care, and it's such a, I feel, thorough kind of analysis that you have about the whole thing.
Thank you.
It's just so lovely. So then, in terms of, you sort of touched upon the fertility kind of aspect of this. So what I got from part of the management was that, just the act of a period, so the shedding of the endometrial lining, you need to sort of have that, in order to not have a build-up, I guess, over a few months. So in terms of fertility, are those kind of connected? You're not ovulating, so how is that all kind of being managed when you have PCOS? How can that affect your fertility? long term, and what can you do to help with that?
Certainly. So, in theory, and again, I don't want to sound like I'm lecturing, oversimplifying it. If you adopt early lifestyle measures and helpful measures, so I forgot to mention insulin sensitizers or antidiabetic drugs like metformin that we also can use, and they can help to attenuate the symptoms of PCOS. So if you adopt such measures early on, you might avoid having the consequences of PCOS. Not necessarily, but they would reduce it. But let's say you did not know, and you're in early 30s and you're ready to start your family, trying for 2 years, and you can't get pregnant. So you'd come technically to the fertility specialist, and I don't know why we waste a lot of time asking for what could be the reason. It takes only an ultrasound scan and just asking, do you have regular periods? No. PCOS, you could get diagnosis. So it's really should be quick. Unfortunately, that's not what happens on the ground. So the key thing is to restore ovulation. And the way we restore ovulation is traditionally is by invoking a withdrawal bleed if someone doesn't have any periods, and then starting them on a pharmacological ovulation induction agent such as clomiphene or letrozole. They work slightly differently. One is an aromatase inhibitor, one is an anti-estrogen receptor. Currently, the evidence is in favor of using letrozole as a first-line pharmacological ovulation induction agent, and that is because we've done a few trials and we found that because women with PCOS have several follicles, if you give them the agent without monitoring, they might have more than one egg ovulating, so they're at higher risk of twins.
Right.
So it needs to be monitored,
right,
because the key information is that women with PCOS have higher association with miscarriage, higher association with preterm birth, and higher risk of complications in pregnancy. And all these risks that I mentioned are also increased in twins. So the key thing is to avoid having twins in PCOS.
Right.
It's not that it's a disaster, and I want to make it like, avoid it at all costs. But look, you want a healthy pregnancy, so just have a single-term pregnancy. That is the objective it should be the objective of fertility treatment. And so a lot of patients comes to me and say, I'm PCOS, I will never have children. I'm like, no, the treatment is really simple. You just have a pill for 5 days of the beginning of the period, you ovulate, and you just get pregnant as anyone else. So, and it's very successful. So the restoring ovulation with just the pill have about 80% success chance, and with the presence of ovulation without any other reason for subfertility, there is about 20% chance of clinical pregnancy per cycle. So, it's not a very complex treatment. Unfortunately, not everyone responds the same, and unfortunately, there is less understanding of it and of this management, specifically among fertility specialists, and that's where a lot of patients get exposed to IVF unnecessarily.
Right.
So when they fail ovulation induction, or they don't get pregnant after 3 cycles, a lot of patients get told, you need IVF.
Right.
And I think everyone listening will agree that IVF is more expensive, more invasive, and more emotionally draining. So unless you really need it, just don't expose the patient to it. So pros and cons, it's just about tailoring the treatment and individualizing it, as we discussed. So IVF does have a success, so can increase the success rate in those patients who are not responding to ovulation induction, but I would still maintain, and we recently published an article in Reproductive Biomedicine Online arguing that ovulation induction is the first line treatment, it should stay there, versus others who are arguing that delete ovulation induction altogether out of the treatment cycle and just go for IVF straight away. It's like absolutely makes no sense, and not even ethical, because the first rule of medicine is do no harm. So why would I expose my patient to unnecessary harm if they can get pregnant with just a simple tablet they can take for 5 days of the month?
Right. I think it's interesting because in different sort of conditions or complications with health, women's health, that I've talked about on this podcast and learned about in my courses this year, it's not always the case, or most of the time it's not the case, that the clinician doesn't know or the researcher doesn't know about what the condition is. It's that the patient, doesn't have a background in science, doesn't know much about women's health themselves, unfortunately, because they weren't taught it in school.
Yeah.
But it feels like, particularly with PCOS, there seems to be some sort of block in terms of what a clinician knows. And I don't really understand, because surely it's not a new condition. Like, surely this has been happening for many years.
You're very right in your conclusion. If you extrapolate a little bit further, we did a recent survey of women in the UK and asked them, what is your health priority? What is the thing that upsets you the most in accessing healthcare for PCOS? And unanimously, number one is lack of awareness from health professionals. And specifically, they struggle with GPs, and I'm not, going down. Yeah. I respect everything GPs do in the community, and they do face a huge challenge. I mean, I cannot look after a patient in 10 minutes. I cannot do it. So, with all the respect, it's just that I think it's not covered in the medical curriculum enough, and there is not enough exposure to dealing with it in the community, and what needs to be dealt in the community and what needs to be dealt with in the secondary or tertiary care. And then also the nature of PCOS, because it has so many varied symptoms. So the traditional pathway, you find someone with PCOS going to see the fertility specialist to get pregnant, going to see the dermatologist for the hair, going to see the endocrinologist for the risk of diabetes, going to see the GP for the mental health disorders. But then these specialists are not talking among themselves. So instead of one trip that you'd argue to a specialist PCOS clinic, that this patient will have to make 3-4 trips to 4 different specialists who might not talking to each other, and that further sort of make the patients frustrated because they feel like no one is listening to them. They have these symptoms and each specialist is telling them something different. So it's just about the model of care and the access to healthcare sort of that is needed to change. It is evolving gradually, so we're seeing more and more specialized PCOS and gynae endocrine clinics in the NHS. It's a slow process, but I think I see some winning in it.
I think I hope going forwards it will be better addressed by people that maybe even aren't specialized. Like, as you said, going to your GP. It would be great if that could involve an ultrasound every time. Just going to your GP, you can get an ultrasound and bam, there's your diagnosis. Because as you said, it can be just, do you have regular periods, and looking on the ultrasound. So I kind of hope going forwards maybe that can be implemented. But in terms of giving a piece of advice for people that are listening that are maybe going through this syndrome, or they don't know, or they're going through something and they maybe don't have a diagnosis yet of PCOS, do you have, let's first focus on the patient. Do you have advice for someone going through this, like what they can do in terms of advocating for themselves, or how to bring awareness to this? Like, what are some steps that you think would be helpful for the patient to acknowledge with that?
Sure. As we previously discussed, it all starts with education. And then I think if you have the condition, you need to start educating yourself about what resources are out there. I'm very aware that a lot of it is dull, dry, medical sort of language that could be very hard to comprehend, and I struggle with it sometimes. But I would say just sort of visits the websites that are available from charities. So I mentioned the PCOS Verity charity in the UK, there's PCOS Challenge, there's quite a few sort of international charities that are more and more offering advice and support for PCOS. I mentioned the international guideline. It is available online for free. You don't need to read the technical documents, about 300 pages, it's quite long, but interestingly, and sort of a shout out for the researchers who produced the guideline, they did work collaboratively with lay patient representatives, and they did produce sort of late-term summaries of the guideline and very simple infographics that if you just read them and take them to your GP and say, look, this is what the international guideline is saying, can I please receive that? Can I please tailor that to my specific condition? I think you will be at a very, very good start. And after that is just really trying to find a health professional that understands you. So often I get questions, my GP is refusing to do this to me or to do that to me. And I just say, look, I'm sorry, there's nothing you can do except changing your GP. That's what it comes down to it, and there is a human element into it. 90% of GPs are extremely helpful and they want to help. There is a minority that would just not want to understand this condition. They might not feel comfortable dealing with it, if you ask me something in pediatrics, I'd say I'm so uncomfortable to deal with it. So there is a human element into it. So just be proactive and look for the healthcare professionals that will help you. And finally, join a support group. It's very important. And yesterday we did a webinar with Fertility PCOS charity about support groups at the workplace and how can you tailor your workplaces to support you if you have PCOS. And so I think this idea is emerging, and it doesn't need to be a face-to-face. It could be online, and it's just a peer of people who share your symptoms and share your condition and what you're going through. That could really go a long way to help to support.
Yeah, absolutely. I love that. I think that's great advice and great practical advice. Okay, so I normally end the episode with sort of what are your hopes for this field, and what can you think of that might be better implemented in this kind of area. But I feel like I have an idea, I think, of what, especially based off of EV and the evidence synthesis of conditions like PCOS. But I mean, if you were to say that there are things that you hope for going forwards, to summarize.
So 3 things. Number 1 is better education for health professionals in general, and we are working on this, and we're about to start an online course specific for health professionals in the community. And it will be free to attend, and it's in collaboration with the charity, so watch the space. But this needs to have better adoption from, say, like the Royal Colleges and other sort of stakeholders like policymakers. Number 2 is better data curation. So we are at the age, and maybe thanks to COVID, we've become so much better in capturing data, large-scale data, sort of prospectively in the healthcare system. But not many people are doing it in PCOS, so I'm hoping that we'll have better resources, infrastructure, and methodology to capture large-scale data and produce research at scale to inform clinical practice. And number 3 is have stronger collaboration with the patient representatives. And at EV, we're very mindful of that, and we try to have input from the patient directly into the research we do, because at the end of the day, we are doing this research to help the patients, to help them improve their life. It's not for me. And so it's important to have their input into it, and we're always striving for better sort of partnership with them.
Yeah, that's awesome. I hope for that as well. But honestly, this has just been such a great and informative episode, and honestly so grateful for having you here speaking with me about it today.
Always a pleasure, and thank you for organizing this, and great effort put into organizing this podcast, so really respectful. Thank you.
Thanks.